welcome. You should be here if you are interested in the right to healthcare. Today's presenter will be Jason Dommelgauer. So a little bit about Jason. I guess before I start, my name is Christy. If you have any questions, feel free to write them in the chat, and I will relay them to Jason as the presentation gets going, and I'll moderate that. So any questions, go in there. But Jason Dommelgauer, he, him, his, is the director of the LGBTQ plus Cancer Care and Research Program at NYU's Perlmutter, and I think I butchered that one, Cancer Center. He is also the director of Diversity, Equity, and Inclusion at the Department of Radiation Oncology at NYU, as well as a clinical instructor at the Department of Radiation Oncology at NYU, with a focus on palliative radiation and breast cancers. He has led LGBTQ IA-focused in education development, community outreach, patient care initiatives, and grant-funded research projects at the institutional, state, and national level for over 10 years. And so with that, I will let Jason begin our session today. Thank you, Jason.
Wonderful. Thank you, Christy. So I'm just going to share my screen. And as Christy said, please feel free to let me know if you have any questions as they come up. And it's just a really an honor to be able to speak with you all today. So just some learning objectives as we get started. So really to define key concepts and terminology, identify health disparities in cancer care for LGBTQ plus communities, define some strategies to improve sexual orientation, gender identity data collection, and discuss ways to address cancer care for LGBTQ plus communities. So just a brief background on why visibility matters in cancer care. Visibility matters because it allows us to better tailor care towards the person and not assume things, and really be able to discuss the cancer treatments as well as the needs of our patients. So before we do that, it's really important for us to all have a baseline understanding of key concepts and terminology, especially as it relates to LGBTQ plus communities. So starting off with sex assigned at birth, this is one of the first identities that we are given. And this is really a medical designation given to us at birth. And this is really based off of our external genitalia. That's from our hormones, chromosomes, things along those lines. Our sexual orientation is who we are emotionally, romantically, sexually attracted to. And that's why it's designating the heart. So that's who we are really drawn to, these different persons. Gender identity is how we view ourselves, our own internal identity. And what's important is gender identity actually establishes very early on in our development before the age of 10. So even at the age of 7, a lot of individuals will have a relatively good idea of how their gender identity is. And as we start talking about transgender, gender non-binary individuals, those are individuals whose gender identity is not in alignment with their sex assigned at birth. So just a quick example is if someone's sex assigned at birth was female, but their gender identity is that of a man, they are considered transgender. Or in the inverse, somebody's sex assigned at birth was male, but gender identity is woman, would be a trans woman or trans feminine. Gender expression is how we present ourselves, or external kind of shell. Are we wearing pants today? Are we wearing makeup today? Are we wearing earrings? How are we presenting ourselves? And a lot of times people will fall into the binary of masculine, feminine, but there's obviously a very broad kind of fluid construct that we can exist within. And the notable thing is most of these do not exist in a black and white, all one, all the other, but there is a spectrum of existence that people exist in, and that is fluid, meaning that you're not one thing for the rest of your life, but there is some fluidity as we progress through the various stages of life. It's also important that we are talking about a marginalized minority community, but we actually are a pretty present community. And so there's more recent evidence saying that about 7% of the population exists as part of LGBTQ+, or self-identify as such, and that is a growing population. And of note, there's a growing number of individuals who are Gen Z, who identify themselves, or younger individuals who identify themselves as part of the LGBTQ+ community. About 1 in 5 individuals have self-identified as being a member of the LGBTQ+ community, and a large number of those or identify as bisexual, which is a very understudied, underappreciated community as well. So why is this important? So a lot of times when we're discussing these, a lot of providers will say, well, I treat everybody the same. I don't need to know this information. But we know that treating everybody the same isn't good medicine. What they're saying is they're treating people with equality, per se, and that's giving everybody the same bicycle and expecting every person, regardless of their background, abilities, identity, to be able to successfully get from point A to point B with that same bicycle. But we know that's not true. So we rather teach individuals to focus on equity, and that is understanding a person's unique identity and needs and tailoring our care towards that person. So finding a bicycle that fits that person's ability to ensure that we are able to give everyone the unique tools to get from point A to point B successfully. And part of that is better understanding what are the barriers that our individuals, our community members are facing. And a lot of times we turn to social determinants of health. And that is the environment in which we worship, play, work, eat, and live. And we know that there's a lot of barriers or social determinants of health that impact LGBTQ plus communities. So neighborhood and built environment, do people have access to non-discriminatory housing and or living conditions? Do people have access to adequate health insurance, health care, providers that are knowledgeable, that are welcoming, that are inclusive? Is the social and community context supportive? Are people having supportive family, biological family, chosen families, social networks, access to social networks and organizations? Education, do they have access to LGBTQ plus safe school environments, mental health resources, inclusive education? And economic stability, do people have access to well-paying jobs that offer protected sick leave, that offer health insurance? So there's a lot of these things that we do know that there's disparities within LGBTQ plus communities. And something that you may also notice is a lot of the things that I'm mentioning are not exclusive to LGBTQ plus communities, but also are impacting other marginalized communities as well. And so a lot of these things we can learn and has a rippling effect to improve the benefit for a larger number of communities. And towards that end, it's important for us to recognize the intersectionality of identity. We are not just one aspect of identity. We are a mixture of things. So I myself identify as a cisgendered gay white male or white man, because it's important to know that people who exist with multiple marginalized identities have compounded barriers that impact their access to healthcare, impact their social determinants of health. So a trans woman of color is going to have a very different experience accessing various resources or healthcare systems versus a cisgender lesbian woman who identifies as white. And towards this end, it's important to note that as we discuss healthcare disparities within cancer, it's people who are LGBTQ plus are not necessarily born with greater propensity to develop cancers, but a lot of it is because of the behavioral components or the coping behaviors that exist through one's life that will lead to increased risks of certain cancers. And a lot of this comes from the minority stress theory, which has been developed a while ago. But basically what it says, as we exist within a lived environment where we're subject to chronic low or high levels of stress, people develop coping mechanisms that can be maladaptive, such as eating disorders, smoking, developing anxiety, depression, and using substances to kind of to cope with that. And those behaviors then increase the risks of certain cancers. And so it's important for us to realize that it's that coping behavior from that chronic level of sustained stress that leads to these different disparities in cancer, as well as the unknowns, which I'll talk about in a little bit. So why are we talking about this? So approximately 81,000 SGM or LGBTQ plus individuals. So SGM stands for sexual and gender minority, which is more of the literature research term for LGBTQ plus communities, but about 81,000 individuals are diagnosed with cancer each year. And within the sub-communities of LGBTQ plus, there's different disparities that exist. So for example, lesbian and bisexual women are 2 to 2.3 times more likely to have a cancer diagnosis. Gay men are at increased risk of anal, prostate, and HIV-associated cancers and tend to be diagnosed at a younger age. And trans non-binary individuals are 2.3 to 3 times more likely to have infection-induced cancers. So that can be HPV-related, HIV-related, EBV, or Epstein-Barr virus. So these things that can lead to head and neck cancers, gynecologic, pelvic malignancies, anal cancers, things along those lines. So there's And the cancer continuum is everything from prevention, screening, detection, diagnosis, treatment, survivorship, and end of life care. So we do know that at every step of this cancer continuum, there exists disparities for LGBTQ plus communities, some of which are known and some of which remain unknown. And the unknown we'll talk about in a little bit. I just wanted to focus in on cancer detection and screening, as this is an important component because the earlier we're able to detect a cancer, the more likely we are to have success in treatment and cure. However, there exist pretty notable barriers to preventative cancer screenings, and those include a lack of a trusted and qualified provider, lack of sufficient health insurance, again, circling back to that social determinants of health, prior negative experiences with cancer screening. We know that cancer screening is not really a one and done, but it's something that one needs to repeat more frequently, such as mammography for breast, chest cancer screening. If somebody comes in, has a very negative experience one time, the likelihood of them coming back drops precipitously. And this oftentimes happens for those who are trans identified. So if you're a trans man with a gender expression that's masculine, but you have residual breast tissue or intact breast, and you're going in for mammography, trying to do the best for your own health, you may enter into a room where there's cisgendered women around. There's a lot of cisgender women on the wall. You're put into a pink gown. So you're really, and you're also they may be using your dead name or a name that you were given at birth, but you no longer use. There's a lot of these things that can make this a very traumatic experience that people may not want to come back to. And a lot of the gender screenings that we have now in existence are gendered. So we really don't have established recommendations on how do we adapt our screening recommendations for those who are transgender, gender non-binary, or certain types of cancers that are more specific to a certain subgroup, such as anal cancer. And then again, the lack of knowledge on screenings, and then just a distrust of medical providers. And what we're trying to do is moving away from gendered screening and more for organ-based screening. So whatever organ you have that has a screening recommendation for, that is the driving factor, not, oh, you are identified as a woman, so you're going to get breast, cervical, things like that. And that's assuming a lot. That's assuming you have those organs. And so a lot of individuals who've had hysterectomies or things along those lines where the cancer screenings are going to be tailored already, how do we utilize that organ inventory to address the needs of our patients and make it more inclusive and welcoming? So I'm not going to go through this. This is just something we developed so people have an understanding of some of the more common recommendations as they're tailoring them towards trans and non-binary communities. So this is something that will be accessible in the slides as you can refer back to at a later time. So why are we talking about this? There's a lot of things in terms of treatment conversations that are similar, and there's a lot of things that are unique. So similar things include the biology and physiology of the tumor, treatment modalities. So a lot of times with cancer diagnosis and treatments, surgery, radiation, systemic therapies are the cornerstone, and some individuals may have all three. Some of them may have a combination of one, two, or more. And side effects, a lot of the side effects are going to be the same regardless of how one's biology, physiology is. However, there is also a lot of unique aspects to care decision-making. So treatment options decision. Are we talking about the side effects as they pertain to that individuals? Are we understanding person's sexual behaviors, their sexual desires, fertility preservation? All these various things are important for us to have a conversation about. Are we providing a welcoming space for people to receive care? Are they coming into an environment that they are going to feel welcomed? Are they going to be able to thrive in that space? Are we providing the psychosocial care and resources? Are we providing supportive services, knowing that some individuals may be estranged from their biologic families and may not have the same level of support system or support persons? And are we allowing a space for people to demonstrate their gender expression? There has been documented cases where people who are trans-identified go back into the closet during their treatments because they're afraid that they're going to be misgendered, have their dead name used, and face that trauma on a very consistent basis, especially with radiation for people who may be familiar, where you're coming in for treatment each day. If you're coming in each day experiencing micro trauma, some people choose not to proceed with treatment, and that is spaces that we don't want to exist. There's also the consideration of hormone use in cancer care for those who are under gender-affirming hormone therapy. there's not a lot of data to suggest that hormone therapy increases the risk or worsens cancer outcomes. So a lot of individuals are told you have a breast cancer that is hormone receptor positive or some derivation thereof, and so you should come off your hormones, which could be very detrimental to a person's identity. And so having that informed conversation is very important for that risk stratification with our patients, looking towards the data, which is pretty minimal, unfortunately, but really having that informed discussion for the benefit of the patient and tailoring the care for those individuals. And again, there's lack of definitive data regarding optimal timing of gender affirming surgery and a continuation of therapy in the context of cancer treatments, as we kind of just talked about. And again, kind of circling back to the discontinuation of hormone therapy or delaying of gender affirming surgery can have a profound negative psychological impact and actually worse for patients versus their cancer diagnosis. And as I kind of alluded to earlier too, is the importance of fertility preservation. It's important for us to not assume these are conversations that should be happening with all individuals, especially those of reproductive age. But there should not be assumptions that some individuals, because they are trans identified, LGBTQ community members, that they are not interested in fertility preservation. But it's important for us to have a firm opening space for discussion of prior to initiation of treatments, as we know that some of the cancer treatments can lead people unable to be, leading them to be sterile. Remember that contraception should still be discussed. Do not assume that because a patient is of a certain identity that they are not at risk of becoming pregnant. Discuss cancer treatments. You really want to be on birth control. And also the barrier to care for having a family building for certain individuals can be expensive and includes surrogacy, which is extremely expensive. So just briefly discussing fertility options. And I know there's another talk about fertility. And so I encourage you to go back to that if that's something that's interesting to you. It can include fertility, egg retrieval, freezing, embryo freezing, ovarian testicular freezing tissue and reimplantation, sperm storage, uterine suppression, ovarian testicular transposition. So there's a lot of different resources and options for individuals, but we need to ensure that we're having those communications for people so that they are informed. And it's also the importance of survivorship, thrivership. So a person who's undergoing cancer treatments or has finished them, we really want to instill the importance of survivorship, thrivership, because a cancer is just one aspect of the person's identity and their overall health. We want to ensure that they're being healthy regardless of that cancer diagnosis. But we do know that after a cancer treatment has finished, LGBTQ plus survivors generally report greater distress, more difficulties with relationships, increased likelihood of developing substance use disorders, poorer overall health continuation, and lower satisfaction with their cancer care, treatment, and survivorship. So it just tells us there's ongoing issues and that trauma that we need to continue to do a better job of identifying and supporting our patients through. And then end of life care, we do know we're all guaranteed two things. We're all guaranteed that we're born, and we're all guaranteed that we're going to die. And so that transition is important for us to acknowledge and also be aware that there are additional disparities that impact LGBTQ plus individuals. And LGBTQ plus elders are more susceptible to depression, suicide, substance abuse, isolation, and facing difficulties accessing resources. And this is across the board, not just within cancer. And many feel that hospice and palliative care services are not available to them, or they will not be treated with respect. There's well-documented experiences that many individuals, once they enter such facilities, go back into the closet. They have experiences of people praying over them, trying to help them save their soul before they die. And so a lot of individuals become more isolated because they don't want their chosen family to come visit them because it may out them and put them at risk for substandard care of that concern. Of notable concern too is for transgender, trans-identified patients, they often fear that their wishes to be recognized and die as their preferred gender will be disrespected. And again, there's experiences that if a patient does not have a legal family member, that their biological family, who they may be estranged to, comes back into the picture after being absent for a period of time and buries that person in their sex assigned at birth, which was not in alignment with their gender identity. And so those legal resources are very important for individuals that are addressing or kind of approaching end of life care and considerations. And I've mentioned this a few times, but that chosen lavender family is very important for a lot of individuals who may be estranged from their biological family. And LGBTQ plus cancer patients often have family and support systems that are composed of their non-biological or their chosen lavender family, and they may not always, and such support persons might always feel welcomed or actually be welcome in a healthcare center. And caregiver support groups for individuals or spouses of a same-sex partner may not always feel inclusive. People may not always feel that they're able to share the challenges or the needs or voice the needs that they have in a setting or be welcome in such places. And as I mentioned in the prior slide, there are more complex legal issues surrounding end-of-life decisions and finances. So, and there's also, and this is fortunately growing, there's been a recent publication or news report that Bristol-Myers Squibb is actually going to be collecting sexual orientation and gender identity as part of their clinical trials. And this is going to do a better job at fostering inclusion and diversity in clinical trials to get a better understanding that we are providing the best care from a pharmaceutical company perspective, and understanding if there is any differences in identities and behaviors that can impact outcomes for these clinical trials. So why is it so important to collect sexual orientation and gender identity? And this is how to help the invisible thrive. So there's been a national call. Many leading healthcare organizations are recommending the collection of sexual orientation and gender identity. And this is in an effort to better understand the unique health needs and disparities of the LGBTQ plus community. And such organizations include the US Institute of Health, the Joint Commission, Department of Health and Human Services, and Healthy People 2020. And it's also been part of the Centers for Medicare and Medicaid Services Meaningful Use Objectives. And the interesting thing too is when these calls first came out, physicians felt that the vast majority of their patients would not feel comfortable answering these questions. And so they objected to including these as part of their patient engagement. However, when patients were directly asked through various studies, and that included through the Veterans Association as well as by the Mayo Clinic in Minnesota, the vast majority of patients actually felt comfortable with providers asking the sexual orientation, gender identity questions, and felt that such information was actually important and useful as part of their overall care. However, what's very interesting was findings from a review of these 21 studies felt that while most patients expressed willingness to complete these, many LGBTQ plus persons were hesitant to do so because of that historical fear of homophobia and being denied care or having negative care delivered to them. So what are some of the other barriers to collection? So cognitive barriers from providers, lack of training, limited knowledge, being overly uncomfortable asking, fearing of misgendering, assuming, and then thus hurting the patient-provider relationship, that old mentality of I treat everybody the same, or it's not my role. Somebody else will do that. It doesn't really pertain to me. So what are some of the structural barriers? No SOGI select section in electronic medical records, minimal opportunity for medical doctors or other providers to see what is collected, lack of support from the administration of the institution, or no policy at the department or institutional level for collection or protections of collecting said information. And now there's also the concern of political recoil. So if you seek care, affirming care in a different state, is that going to be accessible and used against you in your home state, which may have anti-gender affirming care bills in place? However, if you build it, they will come. So I just wanted to go over some of the efforts that we've been doing at NYU to try to provide a better space, safer space for people to feel welcoming. So a brief thank you to our leadership team. I really could not have done a lot of this work without them. And so we launched this in 2020 as a way of 4 major pillars to deliver LGBT affirming care, develop strong relationships with the LGBTQ plus community, because we didn't want to operate a we know what's best. Rather, this is by us for us, so really involving the community very early on in these processes. Advanced cancer research, again, helping to better understand and close the gaps, and then implement organizational change. Again, systemic changes that can have a benefit impact, not just for LGBTQ plus individuals, but other marginalized communities as well, or those at the intersection of multiple marginalized identities. So towards these ends, we created a patient and family advisory council. This is one of the first steps we did. Again, welcoming and creating space at the table for our LGBTQ plus patients and their chosen families, either that have undergone or are currently undergoing a cancer diagnosis and treatment, as well as create an opportunity for faculty and staff who are both LGBTQ plus identified and those that are not, who are able to voice their concerns or things they're seeing in the care of their patients, or to create a better space for those at NYU to feel safe and included as they come to work. Creating a welcoming space. So again, visibility is super important. I myself, when I go into a new place, I look for cues. Am I going to be safe here? Am I going to be able to say, yes, I am a gay man. This is my partner. These are my concerns. Or am I going to have to be guarded? Am I going to be kind of given insufficient care, which has happened? I've been judged for how I am as a person because I'm simply gay identified. So we really wanted to ensure that we had some better visibility and provided training. So we really did an assessment of how our providers are. This is clinical and non-clinical providers. How welcoming do you feel that NYU is? How comfortable are you in providing care for LGBT individuals? Where are the gaps that you self-identify? And from that information, we developed trainings that have been given to over 44 different locations. And part of the graduation kind of packet is a signage that says at NYU, we welcome all identities. And that is strategically placed below the kiosks as patients check in, so they can see that there's some level of welcoming. We also really developed the QI project to improve patient level data of sexual orientation, gender identity. And part of this, when we first started this quality improvement project, we had a completion rate of 17% for sexual orientation and 21% for gender identity. But more recently, in these numbers I have to update, we're now hovering around 90%. And so this has been fantastic, as it allows us to have a better cohort of patients to look at to see, are we seeing any healthcare disparities? And some of this data is coming up now. It's very early, but we're starting to see that some individuals are, when they are coming into the cancer center, that they are tending to present with more advanced cases of cancer, advanced stages, as well as different tumor sites. We're seeing more head and neck cancers in our trans community versus our cisgender community. So these are some things that we're now able to start better looking at and starting to ask questions of, why is this what we're seeing, and how do we develop interventions to help curtail that a little bit more. We also hired a dedicated staff. So this Alex serves as the liaison between our community organization, our community-based partners, and the institution, and serves as a patient navigator to help patients navigate this complex system, especially those who may have been avoiding the healthcare for a long period of time. So how can you help? So we ask because we care. This information is, we're not just asking to check off a box, but rather it is really important for us to know this information to provide our patients a tailored approach. We want to make sure that we are giving them basically the Hippocratic Oath, do no harm. So we know that cancer treatments are toxic. We do know that they produce harm, but we rationalize that because we're trying to prevent, we're trying to cure, we're trying to treat, we're trying to extend life, we're trying to reduce symptoms. But we want to make sure that in that process, we're not causing undue harm because we didn't ask about it. Are we causing erectile dysfunction? Are we causing rectal ulcerations? So to somebody that's going to impact their sexual health, which is a major concern of theirs. Are we going to cause infertility to someone whose goal in life was to have a family? So it's important for us to have these conversations so we can work alongside our patients and giving them the best care that makes the most sense for them. And to also recognize that we don't know what we don't know. Improved SOGI collection, or sexual orientation, gender identity, at the individual, state, institutional, and national levels is important, because then it allows us to not just see what's happening at our own institution, but what's happening across the nation, and allows us better able to identify those nuances at the intersection of identities. Currently, no sexual orientation, gender identity collection exists in National Cancer Registry, so we really don't know what's going on across the nation. It's important for us to advocate for better data collection, and we can do that as an own individual, when you go into your doctor's office, you can ask, why have I not been asked my pronouns? Why have I not been asked about my orientation or gender identity? Even if you're just asking as an ally, this can create change. This can start a conversation with your provider, with that institution, where you can then advocate that and advocate on behalf of those who may not feel safe to advocate for themselves. Advocate for provider staff training, push the envelope for future funding to really provide opportunities to do better national studies. And then other things that I may not have thought of, people may not have thought, but you can think of that as a way to really promote that inclusion. And community involvement, I can't emphasize more how important this truly is, because I really think that nothing about us without us should be the standard, because we don't know what we don't know again. And it's important for our community partners to help us understand where the gaps are in their environments within their communities, because it may be different from another organization with different community partners or different individuals that they serve. And so really pulling in and creating those partnerships early on is extremely important, and also ensuring that everything that we learn and do gets recycled back to the community, because that's where we're trying to address change. We're trying to impact change by understanding our communities, and we want to ensure that that information is brought back to the communities and feel that that their words and their voices were heard. And then for those who may be more interested in going a little bit deeper, there's other opportunities for both community advocacy as well as developing cancer researchers. So 2 opportunities that are happening in the near future. So the 11th annual LGBT Health Workforce Conference, which is called Emerging Challenges and Opportunities in Healthcare, will take place in New York City in April. And there's also a SGM Cancer Care workshop, which is a curricula to develop advanced research and education specifically within sexual and gender minorities. So these are both opportunities that one can either apply for or attend in person. And then at NYU, we're hosting the first annual The Science of Cancer Equity in Sexual and Gender Minority Communities. And this is happening in October this year. And this is an opportunity for researchers, clinical providers, community partners, or just individuals who are interested to come and discuss where are we currently at in terms of our understanding of the barriers, the gaps, the currently known literature, and how do we put our collective minds together to develop strategies to identify future gaps or help close them further. So please use the QR code if you're interested in participating. And I'm just going to leave you with this final thought that no one should feel scared about being treated differently because whose hand they're holding as they wait for the doctor to arrive. And this is from the National LGBT Cancer Network. And we really want to ensure that people feel welcome coming into the cancer places for treatments. A cancer diagnosis is already a life-changing event. People should not be concerned that they're not going to be able to receive care or receive substandard care or not be able to be who they truly are because of them being a member of the LGBTQ+ community. So we have a long ways to go, but we're really optimistic that we're collectively together, we can work towards closing those gaps and ensure that everybody has access to the best care that they deserve. So if any questions, please feel free to ask any questions before the end of the session, or if you have any questions that you would like to ask offline, feel free to email me at jason.domagauer@nyulango.org. So I really want to thank you all for your time. I'm going to stop sharing and happy to answer any questions anybody may have.
Hi, Dr. Domagauer. It's Megan. How are you?
Good, Megan. How are you doing?
Good. I was just curious, and you may have covered this. I was popping in and out, but kind of a 2-part question is one, if somebody as a patient does feel like either they were, part and parcel of just any discrimination, or that they didn't receive the care, that they're entitled to, or that they felt they should have had in that moment, what is the best course, both advocating for themselves, but then also, speaking to some of the wonderful work you and your team have done more like on an institutional level as well? Like, is it best to speak to your provider? Is there a specific department that individual should go to?
So that's a multi-part question. That's a really important one. So I think a lot of times it depends upon what happens. So microaggressions, macroaggressions, things along those lines, and then how comfortable a person feels for advocating for themselves. So it's something like a provider used the incorrect pronouns or misgendered. Sometimes addressing it at that time may be the best component. If there was overt discrimination, oftentimes institutions will have mechanisms in place where you can report that, either a patient feedback form that gets filtered through human resources or some derivation thereof, which can then gets filtered back to the managing office of that specific program. If it seems like the institution is not a welcoming space or it's not really addressing those concerns, there's other patient advocacy locations. So you can have GLMA, you have various legal representation that are focused on LGBTQ plus communities. So those are some of the things that can be done. And so there's various ones, but oftentimes there's nuances to what are the protections in said states, what are the protections or non-discriminatory policies at specific institutions. One of the things that we're trying to do at NYU is we developed a program called SED, which stands for Support, Accountability, Information, and Discussion. And what that is two-parter. One is to provide a safety net for providers that if they have a patient coming in, that they don't feel they have the resources available or the proper training, they can meet with us. We can kind of prep, if you will, that patient encounter. Or on the flip side, if an encounter already occurred and the provider felt like it didn't go well, which has happened in our institution before, that we will then debrief with that provider. And we kind of have an opportunity to reflect upon what was the situation, what was said, what was done, where do you feel that there is disconnect, and then also combining that with human resource, basically a safe space that people can learn from. So not really of the, you did something wrong, so you're not able to ever work with said patients again, but more of how do we learn and grow from these situations and advocate for better training of individuals. So that's kind of meandering way of answering your question, but there's a lot of different resources available that one can turn to depending upon the level, institution, and the patient's comfort. My pleasure, yeah. Any other questions that I may be able to help answer for anyone or direct anybody to any resources?
I thought you did an awesome job. Very, very enlightening of things. I come from, well, breast cancer thriver, but also teacher. So I look at a lot of this and like, ah, yes, this is great information, even just from the education standpoint too, and sharing it in a different way that's helpful.
Yeah, I'm glad it was helpful. Yeah, and like I was saying early on too, it's although we're speaking about LGBT specifically, you can copy and paste a lot of the barriers that individuals experience and then apply to other marginalized groups. And so breaking down that siloing and really working with individuals who work with various marginalized identities or various communities is really important because we can collectively work and build, progress people forward.
I'm sure this is somewhere, but will this presentation be available afterwards?
Yes, there will be. And if anybody has any specific questions or requesting any specific resources, feel free to email me as well, and I can send you the resources that I'm aware of, and more than happy to share anything that I discussed too.
Looks like
I'm I'm going to put my email one more time in the question. Yeah, I put my email in the chat for anybody who does want to send me. All right, I hope everybody has a wonderful, I know we're close approach time, so thank you again for the opportunity to speak with you all today. And I hope you have a wonderful remainder of the summit, and thank you all for being here, for all that you're doing.
Thank you very much. Awesome job.
Bye, everybody.